Assalamu alaikum. This is Dr. Hassan again. Very quickly, I just want to tell you again, I don't want to waste anybody's time. So I want to tell you about the what I call the differential diagnosis trick. And this is something that I use whenever I go see a new patient. And so it's not really a trick, but it helps get you to the right diagnosis, I would say about 90% of the time. And so it's very simple. Whenever you hear, you have a new patient, Dr. So and so, please go see this new patient. And then you ask a simple question: what is their chief complaint? Which is basically, why are they here? And for this example, I just chose shortness of breath. So our pretend patient is coming to you today for shortness of breath. And so what I do is basically think of the most common 5 or 6 things that come to mind when you think of shortness of breath, and that is COPD, CHF, asthma, pneumonia, pneumothorax, PE, anemia, just the most common stuff, right? And so what I do is I think about all these things, and I have a list of questions for each one. So for example, COPD, I think about dyspnea on exertion, meaning that the patient gets short of breath whenever they exercise. I think of wheezing. I think of chronic coughing. I know they don't have JVP, and I know they shouldn't have pedal edema. And in their physical exam, I'm expecting to see a barrel chest. I'm expecting to hear wheezing. I'm expecting to hear a decreased entry through the decreased air entry throughout their lung fields. I'm expecting some cyanosis, maybe some puffer lips. I also make it a point to ask in my history and physical smoking history. I ask about occupation. Maybe these people work in mines or they work as cooks in open flames. Fun fact, people in Indonesia, most people that have COPD are women because they still use open flames and open fire to do cooking. And so occupation is very important. I ask about family history. What if they have alpha 1 antitrypsin deficiency that runs in the family that predisposes patients to COPD? You think about amyloidosis. You just ask all these questions that can lead you down the COPD path. So let's say you ask all these questions and you're not getting all the right responses. So let's go on to CHF. So you ask the patient, hey, sir, are you waking up at night gasping for air? And they say yes. All right, so you have paroxysmal nocturnal dyspnea. You told us that you have dyspnea on exertion. You have leg swelling. You've having dry cough. You've been gaining a lot of weight recently. When I do your physical exam, I'm seeing JVP. I'm expecting to see some pedal edema. I start to hear your heart, and I'm hearing S3 gallop. And then when I ask you about your family history or your past medical history, you're telling me that you have a cardiac history, 2 MIs in the past. You tell me that your father died of an MI. You may have had hypothyroidism, which can predispose people to congestive heart failure. Myocarditis is a cause of congestive heart failure. You can have Lyme disease, which causes congestive heart failure. Chagas amyloidosis, hypertension can cause congestive heart failure. And so all these things I make a point to ask in my history, and that would lead me down the CHF route. So let's say he says no to all of these, and he tells you, I have coughing at night. I am always wheezing whenever I have these attacks of shortness of breath. Doctor, this happens to me all the time, at least two times a month or 3 times a month. I have this chest tightness. I have seasonal allergies, doctor. So I always ask about seasonal allergies when I'm thinking about shortness of breath. If I went down COPD and I went down CHF and I'm not getting anywhere, ask about allergies. And they tell you, I have seasonal allergies. it's really bad. I have to take a Zyrtec or I have to take an antihistamine all the time. Um, they have prior asthma attacks in the past, and then I go do their physical exam and I hear end expiratory wheezing throughout their lung fields. I look at their skin and they have rashes, and they have atopic dermatitis. You look in their nose and their mouth and they have nasal drainage, and they have turbinae in their nose that are hypertrophied, signaling chronic allergies. You ask about their family history, and everybody in the family has asthma or some sort of atopic dermatitis. They have history of allergies, like we talked about. They have childhood asthma. And so that tells me that this person is now suffering from an asthma exacerbation. And so on and so forth. And again, same thing with the pneumonia. So you ask about cough, is it productive? They have fevers. They're telling you they have chills. They're having chest pains. You ask about their physical exam, or you actually do their physical exam. You don't ask, but you hear decreased air entry to one lobe, for example, like the right upper lobe. Um, there's decreased percussion when you percuss the chest. All the other lung fields sound the same except that one lobe that is decreased to percussion. You ask them about, if they had any recent viral prodrome. Flu can predispose somebody to developing a pneumonia. You ask if they have any neurological problems, a recent stroke or a recent epilepsy, which can lead to aspiration pneumonia. Carcinogen syndrome is genetic, cystic fibrosis. COPD and asthma can also lead a person to go into a pneumonia. And obviously, smoking is just the worst thing that any human being can do, because it's basically a death sentence. None of these worked out for you. Great. Then you come down and think about pneumothorax. Did this person have a sudden shortness of breath? Did they have chest pressure? Um, Are they having trouble catching their breath? Is it a young, tall guy, hypoxic and a fast heart rate? Then maybe you want to think about, pneumothorax. You do their physical examination, and you see that there is no air entry at all to one side of the lung fields. And then you can ask if they have a family history of Marfan syndrome, for example, which predisposes people to pneumothorax. A recent trauma that can be, tension pneumothorax. We talked about Marfan syndrome. COPD and asthma, you can have these blebs from COPD that just spontaneously cause a spontaneous pneumothorax. Recent procedure can cause tension pneumothorax. Smoking is the problem for all of these things. All right, it's not a pneumothorax. Let's talk about PE. In a PE patient, sudden shortness of breath. Patient tells you he has very sharp pain whenever he inspires. He has cough that brought him blood. He's lightheaded. He has a fever. He's sweating. When you go to do his physical examination, you find out that his vitals, he's hypotensive. This is a very big deal. If you have somebody who is hypotensive and has a sudden shortness of breath with chest pain and coughing with blood, this becomes your biggest problem. This becomes number one. But you also want to look at their legs, look for signs for DVT, like a Hoffman sign, tachycardia. Are they in a cast? Are they immobilized? Are they in a wheelchair? Are they pregnant? Are they a young woman that uses oral contraceptives to try and not get pregnant? All these things predispose people to PEs. And if you hear these things and shortness of breath, you want to make this connection right away. For the history, you want to ask the patient about prior blood clots. Has he had a stroke? Has he had an MI? Does his family history include MI, strokes? Does he have a diagnosis of factor V Leiden, protein S, protein C deficiency, antiphospholipid? Are they diagnosed with SLE? basically things that can cause somebody to have DVTs and clots. And then anemia is, if all these things are ruled out, anemia is always a possibility. Look at your patient. Are they pale? Are they having scleral icterus? Are they, are they having blood in their stool? I'm kind of skipping to the physical exam because I think you've kind of gotten the gist. For anemia, you want to ask them if they, you want to know if they're alcoholic. Maybe they're having B12 deficiency and not just acute blood loss anemia. Think about surgery, acute blood loss anemia. Trauma is the same thing. Malignancy. So in malignancy, you have iron deficiency, but it's not acute blood loss. Even if it is acute blood loss, like colon cancer, sometimes it's just anemia of chronic disease. So you want to think about all these things. People with rheumatoid arthritis have anemia of chronic disease. You want to know if your patient is a man or a woman. Is it a young woman who's having regular menses and is okay to be anemic to the 13th and the 12th? You want to ask about celiac disease. Studies have shown that a lot of the hospitalized patients, actually 9% of all hospitalized patients with anemia, have undiagnosed celiac disease. So if you have anemia and you did a colonoscopy and nothing is showing, and you're still having iron deficiency anemia, you should do celiac serologies to rule out celiac disease. Ask about diet, ask about bowel habits. Crohn's disease is another one that causes anemia. I'm sorry this lesson took forever, but I wanted to drive home the importance of differential diagnosis before you go see your patients. You want to have a list. So what I generally do is, they call you and say, hey, you have a patient in the ED, and you say, what's wrong with them? And they say shortness of breath. So I write ED room 1, shortness of breath, and then I just do or think about all the things that we talked about. And then whenever I go to the room, I ask questions basically to guide me. So I go here, I go down this road until I say, oh, this sounds a lot like this road right here, and I'm pretty confident this person has pneumonia. And so I don't have to go wasting my time with other more expensive tests. Like I wouldn't get an echo for my CHF. I don't have to get PFTs for my COPD guy. I don't have to give him inhalers for my asthma. I don't have to go get expensive x-rays or CTs for PEs and pneumothoraxes. So all I'm going to do here is basically prescribe my patient antibiotics, maybe get a chest x-ray, figure out what kind of a pneumonia it is, do some blood cultures, and there it is. So you're going to save yourself time, and you're going to save your patient money, and most of all, you're going to be a better doctor. Thank you again for listening to my very long-winded lecture, and I hope it wasn't too long. Thank you so much.